Welcome to Mind Over Matter. Today it's a pleasure to welcome Tom Posever. He's a research psychiatrist, director of research at the Bay Cove Mental Health Center.
That's right. Yeah.
And today we're going to talk about schizophrenia, research ethics. So maybe a good place to begin would be to perhaps define and maybe give us an overview about schizophrenia, and then we can move on to some of the treatments, some of the research, and some of the research challenges.
That's an excellent starting point, George. I think the public hears the word schizophrenia a lot, and it's often used in sort of a colloquial context, or you hear a news story where that word is used. And it's used more in the sense of the classical definition of schizophrenia, you know, split mind. People sort of associate the word with multiple personality, actually, which is a very different kind of condition. Mm-hmm. But in psychiatry, for years, for the last 40 years or 50 years, we've been talking about schizophrenia as a different kind of an illness. It's an illness that really involves a lot of different dimensions of a person's personality, their thought processes, their perception, their volition, their ability to think clearly, ideas that they have, and it's an impairment in all of those areas that really constitutes what we call schizophrenia, in contemporary times. And psychiatrists have obviously a manual that gives you a bit of a formula for making the diagnosis, and that's how we try to use the language these days. Mm-hmm. And there's a lot of really interesting things about that. One of the things that comes out of it, the definition of the disorder really is based on a psychotic dimension. So people who have this condition have to have one of a couple of different types of problems with psychosis. So either problems with their thinking, problems with delusional ideas or thoughts, disturbances in their behavior, gross abnormalities of behavior, hallucinatory experiences, and the final category that they have to have one symptom from is a category that we call negative symptoms, things like not really being able to generate energy to do what you need to do during the daytime, or to meet your level of sort of social expectation. So if you have two of those things, and you have it for a long enough period of time, at least 6 months, and you have a loss in your ability to do the things that would be normally expected of a person at that station of life, that's what really constitutes the diagnosis of schizophrenia in the contemporary sense.
Now let me just say I'm 18 years old and I'm suddenly having major difficulties. Maybe you could go over that again briefly. How do I know whether that diagnosis fits me or not? How do I know if I'm a schizophrenic?
Well, that's a very good question, because some of the audience will probably know that a lot of people who wind up with the diagnosis of schizophrenia, have this disorder, develop their first symptoms around late adolescence or early adulthood. It does happen later than that, but that's a very common time. And the things that a person might notice, for example, would be that they're not sleeping well at night, and they're starting to develop an eccentric interest in something that seems a little bit out of the ordinary. They may not be able to keep up with their schoolwork as they once were able to. They may start behaving in odd ways, like collecting things or hoarding things. And then they may start having perceptual disturbances. They may start feeling that some external agent is talking to them. They may get paranoid and feel that people who normally care for them and love them are plotting against them in unusual ways. And all of these things, of course, are not really understood necessarily by the person who's experiencing them, and so they may act as if they're simply real elements in the environment that they need to respond to. So those who are close to a person having these kinds of problems might notice that they've gone through a change, there's something different about them, something worrisome. And frankly, it can happen in a couple of ways. It can happen very abruptly, where within a matter of literally overnight or a few days, symptoms like that can develop. Or it can happen in a more gradual way, where the person changes over a year or two, and parents or close family members look back and notice that somebody has really changed.
But maybe back when I was 12, there was nothing that might have suggested that I was heading in this direction?
Not necessarily, and this is the sort of interesting thing about the diagnosis. There's a lot of work that's been done trying to find out what we can observe in childhood that really predicts the diagnosis of schizophrenia. And there are some correlations, and there's some new research that actually, I mean, sometimes you want to be cautious about how to describe this in this type of a form, because we don't want to generate anxiety in people. But what has been looked at are things like subtle neurological changes, things like, motor reflexes, and a person's development of coordination at a very early age, social adaptivity. Some of those things correlate and others don't correlate with a later diagnosis, but nothing is predictive, and that's really the best thing to keep in mind for, for any member of the public who's thinking about this, not to worry about your son or daughter because they may have, some trouble, writing without fumbling with their pencil, that sort of thing.
Obviously, if someone in your family has it, it's quite prevalent, but overall, what are some of the epidemiologic...
Yeah, the prevalence in the larger population is relatively uniform worldwide at about 1% or slightly less or slightly more. There may be a little bit higher incidence in Ireland, and there's some reference to that you will hear. Nobody really knows what the reason for that is.
1% of the general population?
Of the general population, lifelong. It's one to possibly up to 2%. And one thing that really is sort of a very interesting dimension of this that has a bearing on everything that we know about this disorder. We call it a disorder, but it's defined by what we observe in people. And what we observe is really a long way from what might be causing the trouble. A person's behavior is a very complex thing, and you can't draw a straight line between a person's behavior and something genetic or something infectious or something that has to do with trauma or whatever. So when we define a disorder like schizophrenia on the basis of what we observe in people, we always wind up with a basket of different causes that result in this observation. So I think that this is really a profound issue in understanding schizophrenia. It means that we're always dealing probably with what we call a heterogeneous group of disorders, many different primary disorders that result in these behavioral and cognitive problems. We call them all schizophrenia. Then when we go to study them, they all get mixed in the same group and dilute the data, so we never get really the best information about any one of those possible subtypes. So this is always sort of an overriding theme in the work that we do and in making the diagnosis. One of the things that's interesting, when you teach about mental illness to medical students, a lot of medical students will scratch their heads and say, gee, Dr. Posever, I mean, I was at the hospital last week on my rotation, and I saw people with the diagnosis of schizophrenia who were hearing voices and who, dressed in a strange manner, had a hard time communicating with their speech. And then I saw other people who, weren't noticeably different than, weren't noticeably unusual, but who also had the diagnosis. How do you explain that? And this is one of the reasons, because as long as they meet this basic criteria that we use, in contemporary times to diagnose schizophrenia, that's the best diagnosis that we have. And when we get a better one, we'll certainly start using it. But that's really what we have at the moment. And so it really is a reason to be very cautious and very sober about making absolute statements about how well somebody can do, because some people can do very well, others do quite poorly and are very troubled. But it makes it important to keep that in mind about the nature of the condition and what we know about it and what we can do to help people with this condition, all those things.
Maybe this is a good point to ask you about prognosis. In other words, we'll get to specific treatments, and then obviously we want to spend some time on research. Maybe some comments about prognosis?
Yes. Schizophrenia, even as we define it, we pretty much, there's agreement that it's a lifelong illness. And there's a lot of different ways that people will respond to treatment. Some people do very well, and they may be troubled by don't reach their goals in life that they perhaps set for themselves, but they're able to have normal or satisfying social relationships, sometimes live independently, work a job, and feel productive and very fulfilled. They may from time to time be troubled by another episode of either feeling suspicious about things or hearing voices, or having problems with depression, but they get along reasonably well. And then there are other people who are much more troubled by symptoms that we haven't seemed to find solutions to, who always hear voices, who lose a lot of their ability to relate in a casual or normal way and seem a bit unusual or odd. And for those folks, it depends on how severe their symptoms are. Sometimes they need to live in residential settings where they're supervised, or they need to live in hospitals for longer periods of time, or they need a lot of support from the outside to really keep them going. But there's a range of outcomes.
But in terms of, say, our audience, the diagnosis doesn't necessarily mean hospitalization or protracted withdrawal from the community.
Certainly does not necessarily mean that. And that's one of the nice things about some of the new treatments. The treatments, people who know about, who have family members again, or who suffer from the disorder, know that the treatments are far from perfect. But they continue to improve, and there's a lot of hope. And some of the treatments that have come out, we'll be talking about this probably a little bit later on the show. Some of the treatments that have become available in the last 10 years, and medications, are much more helpful in various ways for people who suffer from the disorder.
So it's fair to say the majority, even first break, are not necessarily hospitalized. Most are treated in the community.
I would say that most people who have their first break are hospitalized, and that's usually the starting point for making a diagnosis. And of course, a lot of times when we talk about treatment, we focus on medical dimensions of treatment or medication treatment. But there's really a lot more that goes into it. Obviously, there are enormous consequences for the individual as a person, adjusting to a diagnosis, suffering the change in identity, adjusting one's life goals, working with families to help them understand and educate them about the illness and the process and the treatment, and working with the community to really help people fit in. So those are all very important parts. And in a system that's working properly, you really get a lot of that in a package. And in the best of circumstances, all those things are attended to in treatment.
Well, we'll take a break, and then perhaps we can talk about some of the current treatments.
Sure.
Thank you.
And so, I get this phone call from this insurance company. Normally, I don't pay any attention to these kind of calls, but it sounded like such a good deal.
What was the name of the company?
I hadn't heard of it before, but all insurance companies are pretty much the same, aren't they?
How much money did you save?
The premiums were a third of what I was already paying.
Sounds too good to be true.
Each year, countless consumers purchase insurance policies that are misleading or unnecessary. If you feel that you're in this position, contact your State Department of Insurance, because knowledge is your best policy.
Isn't buying insurance supposed to make you feel safer?
In RSVP, we don't just want to change the world. We're old enough to know how.
Retired and Senior Volunteer Program is a program for people 55 and over to work in many different capacities in the community.
I worked with sixth graders, and the teacher told me that her sixth graders' scores were much higher than any of the other scores. I was delighted.
Show us a problem, a tough one. We have the skills to find real answers.
They're basically eyes and ears for the deputies.
We have a staff of 300 volunteers restoring aircraft for the museum. When you built the plane, where did you get the parts?
We made them.
Your life experience, shared for a day, a week, a year, that's what it takes to make the world a better place. It takes you.
Maybe it would be good to talk about the treatments that are currently available for schizophrenia. So perhaps we could continue with that.
Sure. There are, you know, we've mentioned this, I think the thing that people tend to look to often as a starting point are medications for schizophrenia. They really are a foundation, and we'll talk about some of the other dimensions of the treatments, George, but there are a number of medications available for schizophrenia. There have been medicines for schizophrenia since about the 50s, and there's been a number of drugs developed from the 50s through the late 70s that were called antipsychotic medications, and we now label them pretty much as standard antipsychotics. And in the late 80s and through the 90s, there's been a development of a number of 4 or so new drugs that are on the market now for schizophrenia that are, I think, a little bit better tolerated than some of the old ones. But what the medicines really do best is that they help people with what we like to call the positive symptoms of the disorder. And
Which
those
are?
Those are things like, for example, auditory hallucinations or trouble speaking clearly. We call that a thought disorder because we observe thought through speech. The medicines can help with that. And sometimes people who have disturbed behaviors, their behavior will get better. And the medicines really do a very good job of treating those dimensions of schizophrenia. They do a less good job, if anything at all, for what we call the negative symptoms of the illness. And those are the things like, you know, lack of generating spontaneous thought, or having a blunted or masked or sort of deteriorated sense of emotional experience, not having any volition to get up and do things, no energy to do things. Those things are less well treated. There are also, as I mentioned earlier, some dimensions of the illness that have to do with thinking, what we call cognitive dimensions, and the medicines, some of the newer medicines are helping those dimensions a bit better. But the medicines come at a pretty high cost. They do, the older medicines in particular, used to make people feel very agitated and restless, a side effect we call akathisia. In 10 or more % of people would develop long-term involuntary movements that would be writhing in nature. And there were a lot of blood pressure problems, dry mouth, constipation, things that were really terrible to suffer. And so you paid a big price to take the medicines for the illness. And that's really, I think, where the focus in the newer category of drugs that have been developed in the last 10 years has really gone, to try to find medications that work at least as well, but which cause fewer problems. So those are treatments that are available. One thing that's really important to keep in mind, and some fairly new information tells us that the sooner a person comes to get medication treatment for their illness, probably the better off they're going to be in the long run. This hasn't been proven in a solid, hard and fast way, but there's a lot of evidence accumulating that shows us that it's good to prevent people from having serious psychotic symptoms, because that probably makes things worse for them as time goes. It may predispose them to having more of them or to losing more of their abilities. There's something toxic about the psychotic experience that we would like to avoid if possible. So that's something that's really important. People if they are having symptoms, to come and get treatment. But of course, you mentioned that it's not just medicine. There's really a lot else. We talked about some of those other important aspects in the last segment, but people really do need a lot of support. You know, they need the understanding of their family. They need a chance to adapt to what they're going through themselves. And a lot of people who are first diagnosed really go through a great amount of rebellion at the sense that this could possibly be happening to them. It's a natural reaction. I mean, we all have that reaction somebody tells you have diabetes, or you learn that you're having chest pain, you have heart disease. It's a natural human instinct to really rebel against that idea, and to deny it sometimes, or to wish it away, or to avoid it because it causes more emotional distress to think about.
So that sometimes translates into refusal to take medication or to go for evaluations and treatment.
It might. And it might also contribute to somebody taking treatment for a short time and feeling a bit better and saying, I don't need this treatment. So, over this episode, the illness isn't active anymore. I don't notice the symptoms. I don't have it any longer. And to stop taking the treatment.
Well, I was just going to say, I think one of the symptoms sometimes also is this denial of illness, and that sets up sometimes a dynamic of tension within the families who are trying to take care of a sick family member. A diabetic will usually see the wisdom in taking insulin if it's insulin-dependent diabetes, and won't struggle with the family quite so much, although there can be some rebellion. But more typically with schizophrenia and the denial of illness, the struggle goes around and around and around with the experience of doing a lot better on medication, the refusal, the families keep pleading and pleading, and then finally get annoyed,
absolutely.
withdraw.
And a lot of different ways that can happen. The families sometimes themselves have a hard time accepting the disability of their son or daughter and can actually contribute to it, which is kind of an interesting twist. I've treated people who themselves, in a very surprising way, young people who have promising futures, gone to excellent schools, et cetera, and who come down with the illness, and within a few years are really ready to accept it and take treatment. But the family members simply just can't, have a very tough time giving up the idea that their favored son or daughter is not going to be whatever they had in mind for them. So that can play into the difficulty. So when it's possible, you want to include whoever is close to the person that has the illness in treatment, in education efforts, and building a network of support. We talked about a bit, in the break there. People need support. Even if they're doing well with their treatment and they're living relatively independently, they need a lot of support. And it helps to have reminders of people who understand that they have an illness, who can see them, with respect and dignity through whatever goes on, who don't treat them any differently than they might otherwise. And those things are really very helpful to people who suffer from this illness.
One of the paradoxes, the antidote to the social withdrawal would be clubhouses and interacting with peers, but at a time in the illness when you don't feel the courage to basically go out and interact with peers, or feel that you'd be welcome if you were to muster the courage to do that. So there's this withdrawal, which is sometimes exactly the opposite of what ultimately might be helpful.
Absolutely. I had a little anecdote that, when I was training in psychiatry years ago, one of the basic ideas was that this was, nearly 20 years ago, and a bit of a different era than now. But the idea was that you did as little for the patient as only what was absolutely necessary, essentially. But when it came to treating people who were seriously mentally ill, people with schizophrenia, there's a bit of a different idea about it. A lot of times people require verbal feedback. If you sit there quiet when you're in a session with them, it's not the best thing. It helps to help them orient themselves sometimes, to give them feedback about what how their symptoms appear, and even very cautiously administered advice about things if it's genuinely solicited. And those types of interventions are more helpful. But reaching out to people and saying, I know that you don't have the energy to want to do this, but come with me. We're going to go down to the social club this afternoon, and we're going to take part in something. A lot of those things are really woven into the hospital treatments for people with serious mental illness and schizophrenia these days.
And work is often key.
Absolutely. Work plays, I think, a very important role. I think that there's been a huge underestimation of what people with schizophrenia are able to do. And in the right setting, it's really terrific to see people feel such a sense of gratification when they contribute either, working in the golf club, or taking care of vending machines, or working in an office, doing computer work. I mean, people do all levels of work with this disorder. Finding the right setting where that can happen that sort of suits their special needs.
But there is a kind of a painful reality as well, in that many of my patients end up working, but it's work that is different from the work maybe they aspired to
Quite right.
when they were much younger. There's a certain kind of honing down of the expectation.
Absolutely. Yeah. So in the sense of treatment, one way of looking at it is that it's sort of a tripod, a pillar. There's medication perhaps in one dimension. There's rehabilitative efforts on another dimension. There's support. All of those are very, very important dimensions. And if you pull any one of them out, people will have more difficulty. So those are important things to keep track of. It's not just a matter of throwing medications at people, although that is really a very important dimension of it.
A couple of words before the break about the new medications, the ones that are currently available. How good are they? Maybe you could just run down the list of 4 and your quick comments.
Well, the 4 that are available at the moment are risperidone, quetiapine, clozapine, and let's see, what's the other one?
Olanzapine.
Olanzapine, thank you, George. There's a momentary blank there. And those are the chemical names. People often know them more by the product names. I prefer to use the chemical names, a little bit more neutral. But they are medicines that have been developed in the 80s and 90s. What they do is essentially they treat the same problems that the older medicines treat, and they're about as good at it, with the exception of clozapine, actually, which is better than all the others. The trouble is that clozapine has some particularly dangerous side effects. One of them is a problem with about 1% of people who take it will develop a very low white cell count, which can be threatening to them. So they have to be monitored, and for that reason, it's by regulation really a second-line medication. But it does have a greater efficacy, and clozapine also seems to help in other interesting ways. It seems to be better for certain people who have trouble with violence. There's some indication that people who have problems with addictions may do better on that particular medicine. There's some other ways in which it's a bit better.
Because some of that may be the kind of commitment to the weekly white blood count that you need to make. That commitment to treatment all by itself indicates some motivation to work with professionals in containing the illness.
Right. If you get to the point where someone decides to try clozapine, if you happen to have the illness, that is a big commitment. And so there are other things about the clozapine that are, it tends to cause a lot of weight gain, as do some of the others. There's an implication about sugar abnormalities, diabetes, constipation, sedation, drooling. There are a lot of things. And some of the other medications as well share some of those side effects. So there's the hope on the one side, and there's the price that you pay for it. And everyone responds a bit differently to those treatments.
So we'll welcome new medications as well after the break. Perhaps you can tell us about some of the research you're doing?
Sure.
Well, thank you.
Log cabin on the lake. Just me and my wife and fishing.
I can tell you what I won't do. Won't just curl up and vegetate.
Do something I've wanted to do since college. Go back to college.
Ir en un crucero. Alaska.
Secure your retirement plans with U.S. savings bonds.
When you think of retirement, you think no more boss, no more responsibilities. But it also means no more paycheck. So where will the money come from?
I have a pension plan where I work. But will I still be working there 20 years from now?
Start saving for retirement now with U.S. savings bonds. They're the easy way to save. They're the safe way to invest in your future. Get details where you work or bank. Or write U.S. Savings Bonds, Department of the Treasury, Washington, D.C. 20226.
Look, you work too hard not to reward yourself when you retire.
Take stock in America. U.S. Savings Bonds.
One more correct answer, and you're the big winner in the Social Security quiz. And here we go. What will the Social Security statement tell you about your retirement? A, the date you should retire. B, how much you can expect your Social Security benefits to be. Or C, what you will owe in taxes.
I know this. I remember getting my Social Security statement in the mail, and I know it's B.
Are you absolutely sure?
Yes, that's my final answer.
Well, you're right. Congratulations.
Retirement planning is not a game. Watch your mail for your Social Security statement and use it to plan your financial future. Remember, Social Security should only be part, not all, of your retirement income. The future is in your hands.
So we're in agreement that in the last 10 years or so, new medications have come along which clearly for the treatment of psychosis are an advance. However, there are still some problems, and thank goodness people like yourself continue to look, explore for even better possibilities. So what are some of the research interests that you have in this area? What are some of the medications that are in the pipeline, and what can we look forward to?
Well, let me start by telling sort of an interesting story, George, about just how the medicines for schizophrenia have been discovered and developed over the years. It starts back in the 50s, and it was mostly that these drugs were discovered by serendipity. But Thorazine was developed in the early 50s, and one of the things that was noticed about it was that it caused catalepsy in rats, sort of made them stiff and they'd, stop moving. So that was probably the best model that scientists had for finding compounds that might be helpful for psychosis or for schizophrenia. And subsequently, because that was the model, the animal model, which the preliminary compounds were tested, all of the medicines that were developed for schizophrenia had a certain category of side effects that included what we call Parkinsonian symptoms, shaking symptoms, mask-like faces, movement disorders, and the whole other basket of symptoms, problems with constipation, blood pressure control. So all the medicines that were developed from the 50s through the late 70s had those kinds of side effects. And it's really been a result of, of the modern molecular biology techniques and knowledge that we have about the brain and chemical receptors, signal receptors in the brain, that has given rise to a different way of looking for drugs. And so now what happens is that we know something about these particular, this is a bit of a technical subject, but the chemical signals that brain cells use to communicate with each other. There are a couple of them that are very important, we think, in psychosis. And so compounds that are going to be tested for schizophrenia, for psychosis, are run through assays and test tubes, then treated in animals before they get to human testing. And we're able to screen out the ones that have these terrible side effects and select for the ones that really have these more specific actions on these chemical receptors in looking for compounds that might help for schizophrenia. So that's how the newer generation of what we call now second generation antipsychotics have really been developed. And it really all started with clozapine, actually, which is not a new drug. Clozapine has been around since the 60s. The trouble was it was given to people in Europe, and because this bad blood reaction was not known, many people died from it. And so immediately it was withdrawn from use and never really went anywhere. But people were always puzzled by it because it seemed so different than the other medicines and very effective. And so in the late 70s and through the 80s, Sandoz took an interest in trying to find out if there was a way to give people this compound safely, and they were really able to come up with the protocols that we now use to give clozapine. But that's sort of a background to how this new generation of drugs has come about. What the 90s has been all about is really trying to find drugs that have the effectiveness of clozapine without all the side effects. So trying to sort of copy it but get rid of the bad stuff. And we've been involved in doing some of that. We participate a lot with pharmaceutical industries and some with academic researchers looking for, studying new compounds to see whether they're good antipsychotics, always looking to improve on what's available now, so find something that perhaps doesn't make people as sleepy or doesn't cause drooling, certainly doesn't require any kind of special blood monitoring and those kinds of things. Some of the compounds we mentioned, the 4 that are on the market, there are other compounds that have been studied. A lot is known about. They're good medicines for psychosis. They're not on the market yet. One that you mentioned in the break was ziprasidone. We've done studies in that drug since about 1991. And it's apparently been accepted, but it's by the FDA for marketing, but it hasn't been marketed yet, so it's probably going to be available soon, I would think. And there are several others that are in different stages of testing. Some of them that are very interesting. They even work by different mechanisms. Some of them, we talk a little bit about these chemical signals. The 2 that are most commonly associated with schizophrenia are dopamine and serotonin. There are some chemicals that are being tested that don't have any effects on dopamine. They just work on serotonin. So it'll be very interesting, in the years to come to figure out, which is always part of our larger interest, why do these compounds work if they're different than the other ones? Why do any of them work? We'd like to know that.
I guess it's not known. When you really look at it carefully, a lot isn't known about why these things work, but we do know they do work.
We know that they do work.
A word about ziprasidone, because I was actually invited to a meeting a couple of days ago, and it looks like it's a matter of a couple of months before it's available. And 2 of its advantages, but I'd be curious around your comments about efficacy, but advantages are no weight gain and no sedation. What's your experience? I understand it's been tried now in over 5,000 people with fairly good results. Your thoughts about its efficacy?
Well, it looks to be at least as efficacious. And when we say efficacious, that's usually a scientific way of saying that it works. It means that it's been studied, and we know that it works, and that's when we use the word efficacious. But it looks like it's as good, at least as good as the other novel antipsychotics. And as you said, it doesn't tend to cause much weight gain. It doesn't tend to cause a lot of sedation. It can be sedating, but it doesn't. People don't complain too much about it. It does have an issue with heart rhythm, which most of the scientists who studied are not that concerned about, but there's a lot of new curiosity, let's say, and concern about heart side effects from all these medicines. And ziprasidone has this effect, and so we're going to need to be careful about that when we prescribe it to people. But it does appear to be quite efficacious. We, of course, doing the studies, weren't privy to what the patients were taking because they're blinded studies. And so we don't know for sure what people were on. But we've actually treated some people through blinded studies and gotten them onto what we call compassionate use open label studies, and have had some people do very well on this drug. And I would say that as a sense of an endorsement of the drug. All the other drugs can be endorsed in the same way. There are people who do very well on them, but there are certainly people who do very well on this drug. And it will be interesting to see how it finds its way amongst the pharmacopoeia that we have to be useful to people.
What about depot preparations? Besides Haldol and Prolixin, are we soon to see Risperidol, for example, available?
I know a little bit less about that, George. I understand that there is something working there, but I can't give an accurate accounting of where how far along the tests have come and what's expected.
What's your experience with depot medication? I know it's only Haldol and Prolixin, but
well, it's it's nice to have something that can be given for people who are willing to take medicine, who want to comply, but who, when they're not with somebody every day who will supervise their taking their pills, won't do it or will forget or miss. It's nice to have something that you can offer that will stay with them for a long time. And so that's
what's a long time?
Usually at least a week and up to a month, sometimes longer. That's what the injectable forms of haloperidol and flufenazine really do. So it's nice to have that option. There are cautions, of course. When you give somebody an injection that lasts a month, if they have side effects from it, you can't get rid of it. It's there for a month, and that can be a serious problem, so you have to be very cautious about that. But those are nice things to have. Interestingly, ziprasidone is expected to have an injectable form, not what we call a depot form. It's not a long-acting form, but it is an injectable form that might be used in emergencies, for example.
Are there any others that are close to market, antipsychotics?
There are many that are in the pipeline. There's another one called aripiprazole. There's a fair amount of information about that. There's some others that you know, again, are further back. The thing that we're interested in terms of our research, we've been doing a lot of work with Dr. Don Goff and Eden Evans and other people at the Freedom Trail Clinic and Mass General who are very interested in glutamate. Glutamate is another chemical signal transmitter in the brain and has really gathered a lot of interest in the last decade, I would say, as a possible and maybe, you know, a good candidate for why some people have schizophrenia. Has a lot to do with thinking, cognitive effects, and so what we're looking at in some of our research with Dr. Goff is compounds that may help people remember things better, solve problems more quickly, and some of those things that are
schizophrenics or more broadly?
Well, people with schizophrenia, but also more broadly. I mean, there's interest obviously in people with dementias. There's some popular interest in things that a lot of college kids would love to get a hold of drugs like this. I'd be very cautious about that because these things are really intended specifically for people with disorders and not as generally. But the whole interest in whether people's trouble with cognition can be helped along in some way, because those are the most debilitating dimensions of schizophrenia in particular, the things that cause the most disability and change in what a person can accomplish compared to what they expect.
So how many times, we have about a minute left, do you find schizophrenics subsequently with treatment, doing fairly well with treatment, becoming depressed?
It's a fairly common concern, and I'm glad you brought it up, George. One of the main, you know, biggest sort of crises with schizophrenia, I think, is the depression and, you know, the suicidal feelings and attempts that people make. Some studies say that almost half of people who have the diagnosis will at some point make an attempt in their life, and up to 10% will actually complete a suicide. And those are staggering numbers when you think of the, you know, the numbers of people who actually have this disorder. It's telling about the, you know, the disability that it causes and the distress. But some of the newer medicines are also targeting the depression and some of the violent impulses that people have with the disorder. And so we're hopeful that we'll be making some progress in it. There's some studies with clozapine, actually, that are looking at its effect on suicide rates.
So are we properly or improperly peddling hope when we try to work with these people? We have a minute left.
Well, I think that we're always properly peddling hope. I think that's the right thing to do, and I think that, you know, we need to be very sober and respectful of, just as you mentioned earlier, that in spite of the things that can be done to help people, there's still a lot of suffering, and that's something that we all acknowledge. And requires, you know, a great deal of delicacy and sympathy and continued effort. It's really what we're after. But hope, absolutely.
You know, I'm dealing with a number of people who are really now at a point where they're well enough to know how much the illness has cost them. And it's a very, very existential moment in their life. We'll take a break, and then after that we'll talk about some of the ethical dilemmas in doing research in this field.
Absolutely.
Thank you, Tom.
Yeah.
My Youth for Understanding experience was the best thing I've ever done in my entire life.
If you want to learn a language, this is how you do it.
You have to live here and you have to breathe in the country.
You meet a whole new family that are willing to accept you and take you in.
I feel like just like I'm a part of the family. Being involved with the family, living right at home, that has been my best learning experience so far.
You only live once, so you do it, try it, live it.
It was great. It was incredible.
Go global.
The way to go. The cyber cats are moving to a cyber beat. Cyber living, cyber playing cool and sweet. There's even cyber IRS to save a little cyber stress. E-file, it's a cyber gas. E-file, get your refund fast. Step out of the past. 40 million people already know E-file's the way to go.
Use IRS e-file and get your refund in less than half the time. Ask your tax preparer to e-file your taxes or do it on your own computer. You can even sign electronically.
40 million people already know e-file's the way to go. 40 million people already know e-file's the way to go.
Okay, let's talk about the difficulties in doing research and coming up with good data as you try to find new drugs.
Sure. Well, it's a broad topic, as all of these things have been, George, and it's hard to know where to begin. I think one thing that is clear, there's been a lot of attention in the media in recent years. Particularly, there was a Globe article that appeared in November of '98, 4 articles in a series about psychiatric research around the country and some of the problems. And we've had a deep interest in ethics since our operation has been running for the last 10 years. We actually have just written a paper that should appear next month in a journal called IRB, which is on a consent process. So what we've tried to do, and some of the broader concerns, many of them, but one of them, to be a little bit focused about it, is that when you're trying to do research on people who have serious mental illness, an illness that affects their ability to think and their ability to make clear judgments and their ability to remember information and a variety of other things, you have to be very careful that when you tell them about a research study, you're trying to get their consent and you're trying to inform them, you need to know that they really understand what they're volunteering to do, what the consequences specifically to them might be. They need to be able to reason with the information somewhat, and they need to really be able to volunteer clearly. And if you can't do that, you really haven't ethically taken somebody into a study. And so there are mechanisms. There's a long history to research ethics. It would be something that we could talk about in another session maybe. Sure. But what it comes down to in the year 2001, there are mechanisms in place that look over researchers, institutional review boards. At every institution where medical research takes place, they have a legal mandate to make sure that subjects who are entered are given proper consent, that the risks and benefits in the study are commensurate with what's expected and are reasonable, that there are safety measures in place for the subjects, that the people who are conducting the research are qualified to do it, that there are no dramatic and dangerous expected outcomes from the study, and then they have to monitor the entire process of setting up the research in the way that it's going to be conducted and overseeing how it's handled.
So that immediately imposes certain ethical constraints in data collection. For example, I would imagine it's very hard today, given what we know, to do placebo-controlled studies.
It's hard to do them, but they are done, and actually we have done placebo-controlled studies. So the question that a lot of people will ask is, about these difficult questions, for example. If you have somebody with mental illness, how can they be capable of giving their consent to a study when they're having a psychotic episode? And these are, complex questions. I think that they are able to do that. And the consent process that we've really defined involves educating them in one session very clearly and asking them to repeat information back and talk about their judgments and their appreciation and their ability to reason and to volunteer. And then having them seen by a second person who's generally a human rights officer, who's an advocate for them, who in a separate session completely independently talks to them and makes sure that they really understand what they're volunteering for and can reason and judge, and that they're not being coerced or forced their volunteering.
So they have permission to say no.
Absolutely. And they have time to think about it. They usually go home, think about it for a day, and come back. And they're also seen by a third person who is a second psychiatrist. And that person's role is specifically to measure their capacity to understand and to reason with and to appreciate and to volunteer. And they're trained to do this. They look at it in somewhat of a technical way, but they try to make that judgment of the person. And if any of those three individuals doesn't think that the candidate understands well enough or has the capability to volunteer, then they don't get to do the research. So they all three have to agree. It's a cumbersome process. It's inefficient and it's slow, but we think that it sort of has an ethical efficiency because it really, you know, as far as one can do in a judgmental way, goes as close as you can to making sure that somebody really knows what they're getting into and are able to volunteer. Now, this also happens, of course, after the research has been approved by the Ethics Review Board and all the procedures have been reviewed. So that's sort of one way of doing it. There are, of course, other ways. You know, this three-part consent that I described, something that we've been using at our research center for the last 10 years. But there are people who use a single-step consent to enter people even into, say, a placebo-controlled study. And what they will generally do is be very, very cautious about making sure that the subjects understand the research and questioning them. Or they may ask them to fill out a questionnaire or to answer questions that are on a questionnaire. Or they may apply you know, a competency assessment scale, and there are a few of those that are, there's one in particular actually that's being honed towards psychiatric research. So these are some of the ways that we try to at least safeguard the person's choice, their competent choice to be involved in research. But you know, as we talked about, that's not the end of the picture. When you enter somebody into research, and if you're doing placebo-controlled research, you generally want to be careful about who you're entering into a study like that. You need to be sure that you're not exposing somebody to the risk of being treated with a sugar pill. So a lot of times the people that the only people that we're really able to study are people who are already ill because they're taking their medicines and they're having terrible symptoms anyway. Or they, you know, they've been off their medicines because they haven't been complying for a while. And those people are more, it's a good question, but it's, I think, an ethical situation to take people like that into a placebo-controlled study if you protect them if they have trouble. If they don't do well after a period of time in the study, or if they're getting worse, then there should be safeguards in place to take them out so that they don't harm themselves. They should be compassionately treated. They should be communicated with directly, and their consent should be, you know, checked on, what we call sort of continuation of consent. If you have somebody in a study like that, you need to check in on them. You know, the second day, the third day, the fifth day, whenever you are doing your other procedures or whenever you feel that you need to do it, you should check in on them regularly to make sure that they still understand and they still want to be part of the study.
Should they be compensated? Are they?
They're often compensated for things like transportation costs, time and trouble. You know, the amount of money that's paid to them is really very carefully controlled also by the ethics boards because it should not be coercive. We don't want to get into the business of paying people to expose themselves to risks. But there's another really interesting side to this, George, which is that one of the things I think a lot of advocacy groups and people with mental illness feel very strongly about is not having their rights taken from them because they have a diagnosis. And so this becomes one of the things that fits into the ethical balance. We have an obligation both to protect people from being exploited or suffering, but we also have an obligation to give them their rights, their freedom of choice, which really is very dignifying to the maximum degree possible. So that's really the balance that one attempts to reach in allowing people to participate in research. And the research, you know, you say all kinds of things. That, you know, the Globe article was, of course, an expose, and there was a lot of embarrassing and damaging things to the psychiatric profession in there. But the fact that these treatments exist and the medications that we have do exist and that we can offer hope to people also is grounded on, you know, ethical research that we try to do. The research effort in a broad sense is what brings hope for these things.
I don't mean this as a tricky question, but I think it's an important reality. Can you do good research with drug company money?
Yes, you certainly can. And there's a lot of that going on today. Things get complicated when there's drug company money involved. Again, another topic that could be explored in another 2 hours of study, but there is less federal money and available than there was 15 or 20 years ago. There's a lot of very charitable foundations that provide research money for mental illness, but there's less money available. So people like myself need to you have to fund your operation. You have to pay assistants. You have to pay for equipment. So a lot of times what people will do is do work for drug companies. They get paid well, take that money and recycle it back into startup projects that are more of scientific curiosity or of individual curiosity for an academic, and then build a program in doing that. Again, it's a very complex topic, but that's a good point. I think that there are a lot of studies that are sponsored by drug companies that people are very suspect of, but there are also a lot of them that are very courageous. There have been some remarkable studies done, even in with some of the novel antipsychotics, in testing them against placebos and different doses of other antipsychotics, of looking at very high-risk populations for information about suicide, which is important data to get and very costly data. So some of this is funded by drug companies. It's very valuable data to have. It's going to be very beneficial to people with a disorder. Personally, I'd like to see there be available a lot more federal funds for research, and I think that there's not enough. And I think that in general, the trend from moving from public monies to private monies is not a good one for the long term. It may be providing a lot of new drugs now, and we're happy to have them, so not to diminish that value. But I think in the long run, it's not a good policy direction to be taking, and I'd like to see a lot more money.
So when practitioners like myself look at the data, and we're constantly bombarded with new data, I think it's important to know who paid for the studies, but then
absolutely.
I think it obviously is important to look at the methodology that was used.
Absolutely. We're all being bombarded by so much information these days. We have less time to think about how valid and accurate it is, but you're absolutely right. I think you always need to look at who sponsored the study and try to read over the methods if you can. That there's an awareness of the fact that for some reason, because there's so much data generated when a study is done, you can present it in any way you want. And that's what happens often with the money that's spent in pre-marketing trials of antipsychotics and all medications is to show the effectiveness and the safety of that compound. And so the data is collected and presented to the FDA that will support that. And it is a certain degree to the prerogative of the owners of the data, the drug company, what other data they present and withhold. And that's another somewhat worrisome part of the picture.
Yep.
Right. We'd like to know more about that. And if it were academic research with public funding, you would know it all the time. So.
Well, listen, it's been very, very interesting, and I, for one, am very glad there are people like you out there doing the research, because obviously good products do come to market. So on behalf of the Norfolk Alliance of the Mentally Ill, I want to thank you for being here today. Keep up the good work, and maybe you'll come back in a year or two and tell us what new products are now available.
Thanks for having me, George.
Thank you. So now we could,
So.